Hi, thanks, Dr. Masaki. Hello, everyone. I'm happy to give you an update on COVID-19 in Hawaii. So we're going to discuss today an overview of the virus that causes COVID-19, otherwise known as SARS-CoV-2, and also some of the major consequences of getting moderate to severe disease. I'll also be giving a high-level overview of the vaccine that we've heard about so much in the news, and hopefully some of you have gotten your shots already. I'll be covering the highlights of our vaccine implementation plan at the state, and then just ending with some general reminders about how to keep yourself safe. So first, I wanted to remind us how far we've come in a little over a year. We first learned about the virus in December of 2019. At the end of January, the World Health Organization declared a global health emergency, and the day after, the White House declared a national public health emergency. In a little less than a month later, it became a pandemic, and here in Hawaii, we already started to see disruption of services in March. Hawaii's real surge was in August or September, as you can see by the graph below. And we started vaccine planning in earnest in October once it became clear that we were going to have some successful vaccine candidates. The first doses of vaccine arrived here in Hawaii, and the first doses in arms were given on December 15th, so just 2 months ago. We started vaccinating kupuna in mid-January with an emphasis on those aged 75 or older. We've had a mini second surge in January, and hopefully this will be the last one, but we'll see. And then what worries all of us is that the variant strain was identified in Hawaii on January 25th. And since that time, there actually have been several more variant strains identified. So first, let's start with some of the basics. The coronavirus, the name comes from the corona or the crown, and this is from the spike proteins that give the virus the appearance of a crown. These spike proteins are the target of the vaccines. They are what allows the immune cells of the body to recognize this as something foreign and that they want to attack and get rid of. Now, this family of coronaviruses actually has many, many different types. They're very common, and they cause a lot of diseases in human and animals, including the common cold. However, some of these viruses we do know can cross from bats into other animals and then into humans. And so SARS, the original SARS, which is the severe acute respiratory syndrome, as well as MERS, which is the Middle East respiratory syndrome, and now this new one, SARS-CoV-2, or COVID, are examples of these more infectious and potentially lethal or definitely lethal viruses. So how do these viruses, and in particular, how does our SARS-CoV-2 virus get transmitted and passed from person to person? Primarily, it's by coughing, sneezing, talking, shouting, or singing, coming in contact with respiratory secretions. There is some risk of getting this from a surface, and that's why the protocols actually are for good hand washing and also cleaning your workspace, wiping down common areas if you're in a work building, etc. We also know that healthcare workers, well, and now others, but healthcare workers who are caring for COVID patients, if they're not wearing proper personal protective equipment or PPE, they can certainly be a source of transmitting it to others. Now, COVID is happening in clusters, and we know this. We've known this from the beginning, and that's why the precautions have been to really avoid large group gatherings, avoid a lot of activities indoors where you cannot space appropriately. And so sure enough, and we continue to see it even to this day, there remain clusters from family parties or gatherings, funerals, going to bars, people carpooling, people in break rooms in a healthcare facility, but perhaps they didn't wear their mask, or really any break room, churches, prisons. And now, actually for several months, the Department of Health has been publishing cluster reports on their website. And they don't necessarily name specific areas unless it's, things like our jails. But otherwise, they do give pretty detailed reports of where these clusters happen, and then also kind of, in what areas are we seeing more frequent cases of COVID. So a lot of times people ask, well, what's the difference between droplet and airborne transmission? And it really has to do with the size of the particle. If they are a pretty heavy particle, as the SARS-CoV-2 virus is, then, you cough and you sneeze, and it'll generally fall to the ground within 6 feet. I say generally because, of course, many of us have probably had that very huge, forceful sneeze that everybody can hear, like outside of the house, and the neighbors, across the street are like, oh my God, what's wrong with you, right? So those types of very loud sneezes might perhaps go more than 6 feet. But in general, if you're speaking at this normal voice, or a slight cough or sneeze, even if it's in your sleeve, it's generally thought that the virus will fall to the ground within 6 feet. Whereas airborne transmission are very tiny particles. And so things like the measles virus, which is very infectious, the reason it's infectious is because it's very small and can be transmitted for very far distances. Now, there were clusters and outbreaks in Washington State, and one of the largest ones was actually from a choir practice because of the very loud singing, right? And so that was really throughout the whole church. I think there was over 132 people that got infected in that cluster. And so there have been studies since March that have shown that yelling and shouting, perhaps at the TV during Super Bowl Sunday, for example, or those types of things actually can probably transmit the virus further than 6 feet. And that's really the rationale for the different restrictions on sizes of physical gathering, locations, and really the reminder that we should be wearing our mask. Now, on the bottom right of this slide is a slight graph from how quickly does COVID spread compared to other diseases. And so, and this is sometimes called the R0. Some of you may have heard about this reading in the news. But it basically shows, so COVID is at the top, and it shows the R0 of 1.5 to 3.5. And that means that if one person could spread it to 3 other people very quickly. Whereas measles is really at the bottom. And it's so infectious that it actually goes beyond into the next line. So measles and smallpox are definitely considered among the most easily transmitted agents. But SARS-CoV-2 or COVID-19, you can see that it's actually more easily spread than the regular flu or Ebola. Okay. So what about how often can we get it? When can we get it? How long does it take? All of these things, these are related to something called the incubation period and asymptomatic transmission, or the time when you can transmit where you are infected with the virus, where you are infectious, and where you can transmit it to others, but you have not yet developed any sort of symptoms. So in general, the range is 2 to 14 days with the average of 5 to 6 days. So what that means is that if I were to have come in contact with someone today, and that person tomorrow found out that they tested positive for SARS-CoV-2, if we were not wearing a mask, if we were closer than 6 feet to each other, or if we were together for more than 15 minutes, I would be considered a high contact exposure. And I would have to go into quarantine because my friend who is being diagnosed tomorrow was infectious from 2 days before the onset of symptoms and is potentially infectious for 9 to 10 days. So when we say the range is 2 to 14 days, that is the time, that is the incubation period. So that is the time from you get infected to the virus to the time that you actually start showing symptoms. And so most people will develop symptoms around day 5 or day 6. And this is why we tell people that if they have been exposed to someone who's been tested positive for COVID, they should not get tested right away. They should actually wait until day 5 or 6 to get tested. But what the 2 to 14 days means also is that you can have someone infected with COVID and not develop any symptoms at all till about day 13 or 14. It's a smaller number of people, but it definitely has been documented. And so this long pre-symptomatic period is what I was just talking about, where you can be affected from an exposed person, and it's a very long time before you develop symptoms. In the meantime, you've gone out and lived your life for 12 days, right? And so that's why the precautions are so very important, because if, say, I was that person that was exposed, but if I were wearing my mask and behaving, if I were washing my hands good, if I was just really avoiding crowded places or anything, then my chance of transmitting it to others is less. It's not zero, but it's less because I was actually wearing my mask and hand washing and avoiding crowds. Now, the third bullet is really, really important. And so that's why it's so important for everyone to wear their masks and follow the precautions, but also to get vaccinated. And it's because about a third to a half of the cases are transmitted asymptomatically, meaning that they never develop symptoms. And that can be up to 21 days. So again, that's a pretty staggering number and is really what's likely to be accounting for the rapid rise now in the current surge that's going on in the rest of the United States. And so I'm not going to get into all of the graphs, but the lines, but the graph at the bottom shows that the blue line tells us when the test is most likely to be positive. And so the blue line is a nasopharyngeal swab, the PCR test that's done by sticking a swab up your nose. And so that tends to be more positive, within a week, again, 5 to 6 days, from the time symptoms occur. And then there are other ways that the virus is detected. But again, these time periods are really the basis for our guidelines, the CDC's guidelines for contact tracing, what's considered a contact, who should be in quarantine and for how long, and isolation. And so quickly, contact tracing is, again, in the example that I gave, hypothetical, because I've been vaccinated, thankfully. But if I were not yet vaccinated, and I came in contact with someone who, again, tomorrow or the next day was later found to be positive, then the contact tracers would have to ask that infected person everybody that they came into contact with in the prior 48 hours. Okay, and then they are test positive, so they would need to be isolated for 10 days. This is presuming they have mild disease and they're not hospitalized. If you're hospitalized with COVID, the isolation period goes up to 21 days because it means you have a lot more disease and you're a lot more sick. It takes your immune system more time to fight off the virus completely. For me, as the contact of the infected person, I would have to quarantine for 14 days, which essentially means I need to stay in my house, stay in my room, have my food delivered to me, and not go out and, be on my FaceTime a lot. Okay, so if you were to get COVID, what would happen? So the common clinical signs and symptoms are, things by now that we've heard about, right? So respiratory symptoms, runny nose, sneeze, cough, low-grade fever, or sometimes very high fever, but a fever, chills. There's about a third or so that can have symptoms, stomach ache, nausea, vomiting, diarrhea. Loss of smell and loss of taste are pretty classic for SARS-CoV-2 infection. They don't happen in all patients, but if it does happen, chances are quite high that you actually have COVID. And so what the graph shows here is that the clinical symptoms are, milder early in the infection. So here, mild constitutional symptoms, fever more than 99.6 degrees Fahrenheit, dry cough, diarrhea, headache. And then on the lab, in the bottom row where it says clinical signs, these are what you would see if we were to do blood tests on you or chest x-rays. And you'd start to see changes in the white blood cell count in some other labs. But in the stage 2 or the pulmonary phase, now again, this is the getting into the more moderate to severe, this is when you're going to start to see more shortness of breath or low oxygen levels, otherwise known as hypoxia. The hypoxia tends to occur maybe around day 6, 7, 8-ish, especially in people who have underlying lung conditions like COPD, chronic bronchitis, emphysema, or if they have weaker immune systems because maybe they have poorly controlled diabetes or kidney disease, or perhaps they have cancer or they're on some other immune suppressing therapy. Maybe they have rheumatoid arthritis, for example. But the lung phase is really, if you get that, you're going to end up in the hospital. And so we start to see significant lab abnormalities on the chest x-ray on the bottom right of the screen. So this chest x-ray is around illness of day 10, hospital day 6. And normally the lungs are supposed to be nice and black. So in a normal chest x-ray, the bones will be white. The great vessels of the heart, the aorta, superior vena cava, the heart, all of that will be white. But everything else, all the air spaces are supposed to be black, and with just some little teeny fine lines for normal blood vessels. But even to an untrained eye, you can see that there's a lot of white fluffy stuff in these chest x-rays. And that's what we see. And the white areas are a sign of inflammation. Your body's inflammatory cells have caused all these different chemicals and cells to come into not only the lungs, but other parts of the body, and have started this hyperinflammation phase, or the stage 3. And in very severe cases, this is when people will be on a ventilator, they will be on multiple medications to maintain their blood pressure, what we call pressors. They sometimes may be put on a special pump to keep their heart pumping or to keep their circulation going. This is also the phase when we start to see strokes because small little blood clots are happening all over the body, and so there's been increased incidence of strokes or blood clots in the lungs, pulmonary embolism in some of the most sick patients. So it's a bad disease, and that's why we need to prevent it. But again, just quickly, I went over some of this. The common clinical features are the loss of smell or taste early on. And in hospitalized patients, we often see prolonged fever, cough, significant body aches or fatigue, or shortness of breath. But the defining criteria that's going to end you up in the hospital is that low oxygen count. Now, in some patients, you may actually see a rash. They may actually present in florid heart failure because something called myocarditis, where either the virus itself or the inflammatory response has caused a significant weakening of the heart muscles. The blood clots and stroke, I mentioned, that's really in phase 3, although sometimes people present with a stroke. although it's not as common. Now, the COVID toes, and that's what the pictures are on the bottom right, this is more commonly seen in kids, but it could be seen anywhere. And it's basically the little blood clots that are happening all over. They're happening in the teeniest small blood vessels of your fingers and out of your toes. And then in children, there's a multi-system inflammatory syndrome in children, or MISC-C, which really impacts the heart, lungs, kidneys, brain, skin, eyes, stomach, like everywhere. Now, there is some data evolving that suggests there may be a similar syndrome in adults. And there's a lot of actual clinical trials and other things that are going on to help answer this question. But with the MISC-C, it doesn't necessarily happen right away. A lot of times for the children that we've seen here in Hawaii, they had COVID and maybe now are presenting with a variety of other things 10, 15 days later. And we do know that COVID-19 disease does tend to be worse in the elderly and in those with multiple chronic conditions. So it can cause death, as you know. Unfortunately, we've had our share of deaths here in Hawaii, and hundreds of thousands of deaths in the U.S. and even more across the world, over 1 million. But if you're 60 to 69 years old, about 3.6, almost 4% of people who have died are in the 60 to 69-year-old age range. If you're in the 70 to 79-year range, about 8% of them have passed away. And if you're over 80 years old, there's a very high chance, about 15% of those impacted with COVID who are that age may get very, very sick and die. We also know that if people have poorly controlled heart disease, so cardiovascular disease, poorly controlled diabetes, if they have chronic lung disease, chronic respiratory disease like emphysema or chronic bronchitis, poorly controlled high blood pressure, cancer, then those folks have higher percentage or a higher likelihood of dying as well. And if you're the most sick and end up in the intensive care unit, about half of them will go on to die. And that's why prevention is critical. And even if you are able to get vaccinated, it's still very, very important for all of us to continue wearing our masks, to continue to physically distance, wash our hands, avoid large group gatherings, because as you can see, it's pretty significant. And again, many of us, as we get older, have chronic diseases. And then as we get much older, the combination of having a chronic disease plus being older is really a bad combination to have. So the other thing, though, of course, is testing if you have symptoms. And so while we may think, well, this is a time of year, my allergies are acting up, I haven't been around anybody sick, but, I did go shopping or I did have a baby luau to go to, and I was wearing my mask, but, there were a lot of people, right? You absolutely should get tested. And so this is why we tell people if you have any sort of symptoms, even if you're pretty sure it's just allergies or you're pretty sure it's just a regular cold, remember COVID presents like a regular cold, right? And so it's really important to call your primary care provider, talk to them on the phone or do a video visit, and then they will discuss with you all the potential exposures and other risk factors, and then they'll be able to send you for testing. And so this table here at the bottom just goes over the 3 different types of tests that are commercially available for COVID. Now, the Pcr test is what we hear so much about. It tests for the presence of virus, nucleic acids, and proteins that are very specific to a portion of the virus. The nucleocapsid protein, there's some that test for spike protein. Why that matters now, though, is that we have the vaccine. And so there's certain tests that test for things that the vaccine doesn't make antibody to. Anyway, sorry to confuse you. But the idea there, though, is that the testing is important if you have symptoms. The PCR detects the presence of the viral nucleic acid. PCR does not and cannot tell between living and dead virus. And that's why on the other graph, the blue line, the PCR test, actually can stay positive for weeks. But in fact, if you've had COVID and you've recovered and you never went to the hospital, your body, you're immune pretty much. We know that, again, for people that are not hospitalized, your body starts to make neutralizing antibodies by about day 9. And those are the antibodies then that are circulating enough to be able to kill whatever other virus is running around. If you're in the hospital, again, you're sicker, maybe your immune system is a little bit more weak, but generally after 21 days, you're considered immune. Your PCR is going to be positive well beyond 21 days, right? And so that's why it's important to understand these tests. And again, having a positive PCR doesn't necessarily mean that you can transmit it, right? So a lot of it depends on the timing of when your symptoms started, et cetera. And like I mentioned before, about a third to a half of the patients actually don't have symptoms. And so the PCR test is very, very sensitive. And it is quite possible that asymptomatic people may test positive. So the blue line is the molecular or the molecular tests. And they're from respiratory specimens. These are the ones you see in the picture that they collect from your nose. It's very, very, very accurate. Kind of uncomfortable, but it's just brief. And but again, it doesn't distinguish between the infectious versus the viral remnants. The yellow line are the antigen tests that you hear about now. And these tend to be a little bit more rapid. These do, again, kind of pick up active infections in general. But there is a high chance of false negative. It really depends on how it's collected, the time in the course, and other things. So sometimes, and often, and certainly in the hospitals, if a rapid antigen test is done, but then if you're scheduled for, a procedure or it turns out you're going to be admitted, you're going to get the second test through the nose, with the PCR test. Now, the antibody test is from the blood, and that's what's in the orange line at the bottom. So the antibody tests right now, the great majority of them detect the antibodies that are present in acute infection, or IgM, as well as past infection, perhaps up to 6 months. It's a blood test. All it does right now is tell you that you had COVID-19 at some time in the past. Okay, it cannot be used to diagnose a current infection, and the antibody tests that are in commercial use now cannot really tell us if you're completely protected or if you could still be reinfected, with COVID 3 to 6 months later or longer. The antibody test also becomes important because now we have the vaccine. And the vaccine is going to cause our bodies to make antibodies against the spike protein, which are the same antibodies that the regular antibody, if you had natural infection, it would be the same. It would be the same protein. Okay? And so right now, there's actually no test that's recommended to get after, to prove that you have immunity from the vaccine. So since I'm talking about vaccine, this is a kind of a complicated slide, but you'll have them available in your handouts. But going from top left to bottom right, the viral vector vaccines are one type. The nucleic acid vaccines are another type. And the bottom graph just shows, how many vaccines are being worked on across the world. Okay. So the viral vector vaccines are actually, you may hear the AstraZeneca vaccine that's being developed. Or the Johnson & Johnson vaccine. These are viral vector vaccines, meaning that either, actually in both of those, they're not replicating viral vectors, they're non-replicating, meaning that they took an adenovirus, which is super common, and they changed it so that it cannot reproduce, but it carries the SARS-CoV-2 virus inside. And then, or the codes really, not the whole virus. It carries the DNA for the part of the SARS-CoV-2 virus that will induce immunity, so the spike protein. Okay, and so what happens then is if you get, so say this would be the AstraZeneca or the Johnson & Johnson vaccine, you would get the injection, and then just that part of the coronavirus spike protein gene would get inside of your body cells and would just make spike protein. Okay, so with this non-replicating viral vector, they do not, there's not the actual virus, so you can't actually get the virus, the SARS-CoV-2 virus from it. Now, the middle section is the nucleic acid vaccine, and on the right is the RNA vaccine. So that's what Pfizer and Moderna are. These are the mRNA or messenger RNA vaccines. And this is a newer technology. And you can think of the mRNA as the little Post-it note instructions that tell your body to make the spike protein. But those instructions actually get dissolved and eaten up by your body within a few hours. And so there's really, once your body has learned how to make the spike protein, then it remembers how to make the spike protein. And the actual mRNA is gone. And so you absolutely cannot get SARS-CoV-2 from the mRNA vaccines because there's actually no virus, anything in it. It's delivered in a lipid particle that's very cool and fancy technology. It allows it to get from your arm into your bloodstream. And again, within a matter of hours, it's giving the instructions to your immune cells on how to make this spike protein. And then once you have enough of this spike protein, then your immune cells are like, ooh, that's dangerous. I don't like it. Let's fight it off. And that's what our immune response is. And so the Pfizer and Moderna vaccines are, again, this middle column there, the mRNA vaccines. The Johnson & Johnson and AstraZeneca vaccines are non-replicating viral vectors. They're adenovirus vaccines. Okay, so that was a lot of science, but if you like cool pictures, then you can certainly look at the diagrams below. Now, the question that comes up all the time is, well, how do we get these vaccines, so quickly? Normally it takes 5 to 20 years to develop a vaccine, and yet here we are, in under a year having vaccines in arms. And so the answer is really a couple of things. One is, and that's actually not, it's implied in this slide. So the genetic sequence was made available to the world as soon as China sequenced it. And that allowed everybody to get to work very, very, very quickly on trying out different things in the lab and seeing what would make a good antibody response. And all of these important basic science details that are done before you can even think about sending something to a clinical trial. And then, though, that allowed a lot of testing in the animals. That's how you test vaccines initially. And then once it looks promising and safe and they run all those studies, then they'll propose their phase 1 and phase 2 trials. So phase 1 is safety. Phase 2 is kind of immunogenicity and dose. So what also made this really different is that because, again, look at the timeline, right? Because this was declared a pandemic in March, the world had already committed, and the U.S. in particular, and the more wealthy countries like the EU and Canada, had committed funds to help support and essentially support the development, support the trials, and support pre-production before the phase 3 trials were even started. So in other words, the science was so good that they took a big gamble, but they knew that it was going to be really, really important. So none of the science was shortcutted. It was a lot of the processes, the funding, most of the time the phase 1 trials have to complete, and then you can start the phase 2, and then you have to do the phase 3. So what the vaccine manufacturers have done is they did a lot of the testing in the animals, probably actually more robust than normal. And then they combined the phase 1 and phase 2 trials. So then in 6, 9, 12 months, you actually have really good data. And then once some of the preliminary data from the phase 2 trials looked really promising, then they started their phase 3 trials. And so that's how, for example, Johnson & Johnson is expected to file their emergency use authorization soon, as well as AstraZeneca. And so there are still parts of the phase 2 trials ongoing, but phase 3 actually started back in September. And so that's how they were able to accelerate the timeline. These are very safe. They're actually held to a higher than usual standard. There's very close monitoring for at least 1 year. Most of the vaccine manufacturers have a required 2-year monitoring period. The initial vaccines that came out, Pfizer and Moderna, were designed to look their primary endpoints or the outcomes that we look at were on preventing people from getting, the SARS-CoV-2 infection, preventing hospitalizations, preventing death. Part of the Moderna trial was able, again, small numbers, but was able to answer some questions about asymptomatic transmission. But because they went first, then AstraZeneca and Johnson & Johnson were able to closely watch what's happening and design a sub-portion of their trial so that some of those other questions about preventing asymptomatic transmission can actually be answered. So, again, rapid timeline, but I just want to emphasize that the science was not shortcut at all. Okay, so here I went into some of this already, the mRNA vaccines. You cannot get infected from these. They both cause they're both safe, and they both cause very, very similar side effects. After your second dose, then you might have a little bit more fever, sore arm, sometimes chills, body aches, but that's all expected. It's actually a sign that your immune system is working. Now, sometimes people say, oh my gosh, I didn't get anything after my second shot. Does that mean it isn't working? No, it doesn't mean that it isn't working. These vaccines are very, very effective. Okay. But everyone's going to be a little bit different. And so even though the study showed that the second dose tends to have more of these expected side effects, everybody's going to be a little bit different. Okay. But they both are very effective in preventing severe COVID-19, including hospitalizations, intensive care stays, and death. And this is, again, the pictures at the bottom cover kind of what I had talked about before. And so there are, though, like I mentioned, still questions to be answered, and they will be answered in the coming months. One is, how long will the vaccine last? In other words, what's the duration of protection? The related question to that is, will I need a booster? Right? And we're just not sure at this time. There is some early data, though, from Johnson & Johnson that is showing that maybe a booster might promote or delaying it. The second dose might result in a higher immune level than if you get it at a closer interval. However, that is just based on the phase 2 trials, not phase 3. Johnson & Johnson and AstraZeneca actually both have multiple arms with a booster and without a booster to help answer that question. Pfizer and Moderna also have opened up their trials to the younger kids because the Pfizer vaccine was for age 16 and above, but what about the less than 16, right? And Moderna was for 18 and above, and so the Moderna trials already have started enrolling. We don't have any clinical trials for Moderna in adolescents here in Hawaii, but it's going on all over the country and all over the world. Will the vaccination prevent asymptomatic infection? Again, Some data from Moderna suggests it does, but it remains to be seen. The Food and Drug Administration, the FDA, as well as the CDC, continually monitor the data. And so as new credible evidence comes through, then some of those recommendations may change. Similarly, will the vaccination reduce SARS-CoV transmission? So you think, well, yeah, it should, right? I'm immune. But say, for example, say that I got my first dose of the vaccine and I got Pfizer, so then my next dose is due in 21 days, right? So say I got my first dose of the vaccine, but then 2 weeks later, I went to go, I don't know, shopping at Ala Moana, and I was laughing, I didn't wear my mask, I wasn't paying attention, wasn't behaving, okay? And then some of my friends weren't behaving either, and then, we all got it, right? But we didn't have symptoms yet. And then I get my vaccine on day 21, and then I get really sick like 2 days later, right? So then the question is that the vaccine, or did I actually, have the infection? So in that case, I get my nose swabbed again. Very sore, by the way, very sore, but worth it. But I get my nose swabbed again, and then it would show that I actually have the active infection. I'd be like, oh my gosh. Well, it's because after the first dose, you only have about 50% protected, okay? And even after the second dose, you're only about 94 to 95% infected. And so there is still a chance, right, that if I caught the virus, that I could still transmit it to others. And so again, that's another reason why, even if you've been vaccinated, please, please, please wear your mask when you go out. Okay, we talked about the second booster or the 2 vaccine doses and other things that will be answered. Now, at the bottom right is something called, the picture of the V-Safe, which is a very cool, just made for COVID app by the CDC. And it is a way for patients who've gotten the vaccine, it's a way for us to report our symptoms, and it checks on you. Not every day, it's not super annoying, but it's very quick. And once you get your vaccine, you're encouraged to enroll in V-Safe and then just answer a few questions by text. There's also the VAERS, or the Vaccine Adverse Event Reporting System, which is now available online. Like before, only the physicians' offices or the hospitals could report it, and it was this paper. It was very cumbersome. Now it's actually online, and you yourself as a patient can actually report a significant adverse event. Now, with the vaccine, there are a few people who really should not get it. And those are those who have a history of anaphylaxis or very, very severe allergic reaction to the prior dose of a COVID vaccine or to any of its components. And it does contain this thing called polyethylene glycol, which is commonly found in certain laxatives like Miralax and some other things. The rest of the vaccine components are really salts and things that just kind of happen naturally. But it has to be, in a lipid, so a little fat, think of it as a little fat bubble that allows it to get from your muscle into your bloodstream and prevents breaking down right away. And so there might be some instances where people are actually allergic to the fat being injected, right? So those guys would not, the CDC doesn't recommend that they get the vaccine at this time. Anaphylaxis, though, sometimes people are like, what is anaphylaxis? So that is if you're kind of immediately or within 4 hours develop wheezing or severe trouble breathing, if you get dizzy, low blood pressure, and most importantly, do you require epinephrine or a hospital or ER visit? Okay. Now, there are some people who maybe do get a little bit of wheezing or a little bit of rash, but if they were okay and they didn't need epinephrine, they didn't need to go to the hospital, then they can still get the vaccine. They're just going to be monitored for 30 minutes. Similarly, if you're like me and you're allergic to one or several antibiotics and you get pretty bad rash or other stuff, you can still get the vaccine, but you're going to be monitored for 30 minutes after the vaccine. Okay. So again, these precautions, if you haven't yet signed up for your vaccine, then when you do, there'll be a screening questionnaire that you'll be asked to fill out. And then there's, again, some screening questions again on the consent form. And then when you present for your vaccination appointment, someone will double check and make sure that it's safe for you to receive the vaccine. Then you'll get your shot and you'll be told whether to wait 15 minutes or 30 minutes, depending on how you answer. And then there isn't enough information from the clinical trials, but yet still highly, strongly recommended for pregnant or breastfeeding women who are, especially in the healthcare providers, or who are really, by nature of their job, are very, very high risk for getting SARS-CoV-2. Also, immunocompromised persons. So this is HIV or cancer, people on immunosuppressive therapy. And then people with autoimmune conditions. So all of these, again, they place you in a higher risk, even the pregnancy and the breastfeeding. When someone who's pregnant gets SARS-CoV-2, they tend to be more sick than a similarly aged female who is not pregnant. So all three of these things, pregnancy, immunocompromise, and autoimmune conditions, really predispose you for getting very severe illness. And so it's a conversation with your health provider about the risks and benefits. And the easiest way to think about it is, would you want to have the real risk of getting very, very sick, being hospitalized, and potentially dying from COVID, versus a theoretical risk and monitoring for 30 minutes after the vaccine? Okay? But it's an individual decision, and so we encourage you to talk with your provider about it. Now, there are some questions. Sometimes people have had a history of Guillain-Barre syndrome, and right now there's no cases reported after the Pfizer or Moderna vaccines, and so you can receive it. But again, it's a conversation to have with your physician. And then what about Bell's palsy? So Bell's palsy is something that's actually pretty common in the population. And there are a few cases found. Bell's palsy is where just one side of your face, but your entire face is drooping. So you lose your forehead lines, you lose this, as opposed to a very specific part of a stroke in a specific part of your brain, where you're just going to have the drooping of here, but not here. Anyway, very clinical. But if you have a history of Bell's palsy, really the studies thus far show that it probably wasn't the vaccine, because when they looked at the Bell's palsy in the general population versus the Bell's palsy in the clinical trial participants, they were about the same. So again, they may receive the COVID-19 vaccination if they don't have any other contraindications. So just to wrap up then, where are we now? We are still in this less vaccine supply compared to the higher demand. And so, we're in the process of prioritizing. And so the first group is our 1A, our healthcare personnel, people who live in long-term care facilities. And these include patients and staff that work in community care homes, assisted livings, foster homes, developmental disabilities homes. So there are still people in the 1A population who are still getting their vaccine. But what we've started, as you hopefully know, is that we've started vaccinating adults 75 years of age or older. We've also started vaccinating first responders and some of our essential workers. And the Department of Health has a prioritization list. All of the employers are going through and really trying to determine who should go next, so that as vaccine becomes available, then those people will get emails and be invited to schedule. Hopefully by the spring, as vaccine supply gets better, then we'll be able to open up to the adults aged 65 to 74 or those with high-risk medical conditions. And then hopefully by the summer, everyone else. The last part is really a hopefully. The spring one may be more of a reality. We'll see. So this slide just very quickly goes through, the top box just shows the balance, the ethical principles that the CDC and our state is using to help make sure that we really are getting vaccine who are at to those who are A, at the highest risk of death, B, at the highest risk of getting it and transmitting it to others, or C, those, if they got really sick, we'd have, shutdown of essential government functions. And so right now, the frontline essential workers, they actually make up 11% of Hawaii's population. While that number seems small, 250,000 is a huge number, and we do not have 250,000 vaccine doses in the state at this time, and not for at least the next 6 weeks or so. And so that's why it's important to prioritize. So frontline essential workers are those workers whose duties have to be performed on site and require being very close to others and are in frequent contact with people, and they're in sectors that are essential to the functioning of society. So these are just some numbers breakdown. I kind of, for those of you who like numbers, you can see that just the phase 1A is already about 69,000 people. And so many in the long-term care facilities are still being vaccinated at this time. The phase 1B, just the kupuna 75 and older is 103,000. And then when you add the frontline essential workers, that's an additional 126,000. So that's where I said we don't have 250,000 doses at this time, and that's how we have to prioritize. And in Hawaii, because we have a lot of our population that is older, and because many of our sectors are essentially government sectors, stage 1A, B, and C are about 73% of our population. And so, again, that's a lot of vaccine, and we don't have, 800,000 doses of vaccine. We're not anticipated to have that much, not for the next several months anyway. And so that's how we need to continue to be patient, wear our masks, and just hang tight. We do anticipate the vaccine supply will be better by March, and there's a lot of logistical challenges. I know there's a lot of questions. Well, why can't my doctor just give you my shot in the office? I get my flu shot, I get my pneumonia shot in the office. And it's because with these particular vaccines and how they're ordered, it really takes a place and a facility that can do thousands of vaccine a day. Thousands a day. So hopefully by the summer, as we get more and as we get vaccines that can be refrigerated, much like the flu shot, then we'll start to see that indeed you can get it at your doctor's office. More likely, though, you'll be able to get it at Long's and Walgreens first before you'll ever be able to get this at your doctor's office. Again, it's complicated vaccine handling. We just want to make sure that whatever vaccines we're giving are given properly and safely and stored properly. And so, as a reminder, we should still remember to avoid our 3 C's. We should avoid closed spaces with poor ventilation. We should avoid crowds. And we really should try to minimize contact with people outside of our social bubble. We should wear our mask. Again, stay 6 feet apart. I hope all of you were safe during Super Bowl Sunday and had a safe Sunday. And if you, by chance, didn't and you get any symptoms, oh my gosh, please call your doctor right away and get tested, because we don't want any clusters happening because of Super Bowl. All right, thank you very much.